Good morning, students. Today we are going to have a webinar on dyspepsia, a paradigm shift in the understanding of dyspepsia. We have here our website www.sharma.in. You can visit the website and look for more presentations. Over 700 presentations are available on the website for free use and download. Okay. An algorithmic approach we are going to use. Step-by-step approach, or also called algorithmic approach. We use the NICE guidelines. What is NICE? National Institute for Clinical Excellence. So the NICE guidelines are in place from a long time and they keep revising these guidelines. We are going to follow the latest NICE guidelines. Think a while when a patient comes with upper abdominal symptoms. What am I dealing with? Am I dealing with upper GI cancer, esophageal or gastric cancer? Should I not look for H. pylori? Is it drug-induced problem? What is the modern management? These questions should flash into your mind every time you see a patient of dyspepsia. What am I dealing with? Could it be cancer? Should I look for H. pylori? Are the drugs the offending agent? And what is the modern management? So in 1900s, gastric cancers and peptic ulcers were rampant and lot of gastric cancers were there. As we approach 2000 and beyond now to 25, gastric cancers have come down, peptic ulcers have reduced because of the PPI use, functional dyspepsia is on the increase, and GERD is on the increase. And so much so, the cancers of gastric cancers are replaced by esophageal cancers because of the GERD. These are the diseases of the 21st century, FD and GERD. What is dyspepsia? Clinical features of upper GI origin, at least more than 4 weeks duration, pain induced or worsened by food. 40% of the adults have in lifetime, generally benign. Symptoms are poor indicators. That means a patient may not be very symptomatic. He may be harboring esophageal or gastric malignancy. So employ a broader definition. One thing that all of you should remember are the alarm signs. What are the alarm signs? GI bleeding, immediately same day endoscopy, progressive weight loss, progressive dysphagia, difficulty in swallowing, persistent vomiting, iron deficiency, anemia, mass in the epigastrium. And then patient may be of any age, it does not concern. So I give you an acronym, MAD blow. Remember the MAD blow. What is MAD blow? M for mass in the epigastrium, A unexplained anemia, D dysphagia, BL blood, LOW loss of weight. Blood in the vomit or blood in the stools, LOW is unexplained loss of weight. If you concentrate on MAD blow, you will not miss serious diseases. A patient with dyspepsia of 4 weeks duration, upper abdominal symptoms comes. First thing is, does he have the alarm signs? He or she must be examined for a mass in the epigastrium, an unexplained anemia, particularly iron deficiency anemia, dysphagia, progressive dysphagia, and then BL is blood, LOW is loss of weight. Blood in the upper, through the mouth or through the lower GI tract. So what are the alarm signs? Remember, mass, anemia, dysphagia, blood either way in the mouth or in the lower intestinal tract, and loss of weight. If one has, it is imperative that we must evaluate this patient immediately. Okay. What are the symptoms of dyspepsia and reflux disorder? Dyspepsia and reflux disorder are almost identical, but the symptoms are abdominal pain, bloating, nausea, early satiety, burping, and then borborygmia or dyspepsia. Acid regurgitation, heartburn, Epigastric pain, burping, water brush, and dysphagia are symptoms of reflux disorder. So, if you analyze simple dyspepsia by endoscopy, this is the frequency. What is the most frequent diagnosis? Gastritis, GERD, hiatus hernia, no significant lesion. Roughly, one fourth, one fourth, one fourth. These are the various conditions. Gastritis, GERD, hiatus hernia, no significant lesion. Gastric malignancy is around 3%. Duodenal ulcer and gastric ulcer together are around 10%. So, ulcer disease is not that common nowadays, and 3% of your dyspeptic patients are having malignancy, gastric malignancy. That is why the mad blow. What is mad blow? Mass, anemia, dysphagia, blood, and then loss of weight. Okay. The treatment depends upon the classification of dyspepsia. Dyspepsia can be due to these 5 or 6 entities. What are they? GERD. Peptic ulcer disease includes gastric and duodenal. Non-ulcer dyspepsia, functional dyspepsia, uninvestigated dyspepsia. So there are 5 different variants. Of course, malignancy is excluded from this list because once it is malignant, it doesn't come under dyspepsia, though it started with dyspepsia and it should be managed separately. So what are my patients like? The dyspepsia patients. 1. GERD. 2. Peptic ulcer disease. 3. Non-ulcer dyspepsia. 4. Functional dyspepsia. 5. Uninvestigated dyspepsia. That means endoscope is not done yet, and then we do not know whether it falls into any of the other 4 categories. That is called uninvestigated dyspepsia. The treatment, of course, depends on the type of dyspepsia that we see here. What is the differential diagnosis? Uninvestigated dyspepsia, non-ulcer disease, GERD, peptic ulcer disease, carcinoma, functional dyspepsia. Various types are there. Cardiac disease, ischemic heart disease, very much mimics the dyspeptic symptoms. So, all chest pains are not cardiac disease. All dyspepsia are not stomach related. They could be cardiac also. Lung diseases, particularly COPD, is a forerunner for dyspepsia. Liver and biliary diseases like cholecystitis and gallstones are very important to consider. Pancreas and bowel disorders also come under the DD. What are the management options I have got? Lifestyle measures are there. Medical management is there. Endoluminal therapy and surgery. What are lifestyle measures? Cessation of smoking, and then no sleeping immediately after food, at least 2 hours gap between food and bed. Third thing is reduce weight if overweight. And of course, reduce your anxiety and mental tension. These are the simple lifestyle measures. I am repeating: control of weight, weight gain, and then no sleep immediately after food, and then stop smoking, stop mental worrying. And fourth one is patient should not lay down completely flat. He has to lay down in a slanting position as though he is inclined in an inclined chair with a little tilt to the left side of the body. Okay, this is the position of sleep. General measures: lifestyle, advise healthy eating, weight reduction, no smoking. Avoid precipitants, particularly coffee, chocolate, fatty foods, and alcohol. Raising the head under the bed and left lateral position. Having the main meal more than 2 hours before going to bed. Today, what is happening? There is food and then immediately bed. If possible, bed, food on the bed. Both are together. That should not be the way. Slowly reduce the dose of PPI. So, why do I treat this patient of dyspepsia? To relieve pain, of course. Patient has come with pain. To prevent complications and to minimize the recurrence of the symptoms. Recurrence is very common in dyspepsia. I have to relieve the symptoms, prevent complications, and minimize the recurrence. What are the complications? Like three major complications can occur: bleeding from the ulcer site or the tumor site, perforation due to invasion of the ulcer through the entire thickness of the wall of the GI tract, and it can heal with fibrosis and produce obstruction. What are the complications? Bleeding, perforation, and obstruction. These are the complications. Smoking and PUD, peptic ulcer disease, have a very strong association. How does smoking cause peptic ulcer disease? Hastens gastric emptying, so much so the acid contents are propelled faster into the lower part of the GI tract, that is the duodenum, and beyond. Decrease in the pancreatic bicarbonate secretion. The acid is normally neutralized with the bicarbonate by the pancreas, but unfortunately, smoking reduces the bicarbonate, the alkali secretion, so much so acid continues to prevail in the alkaline environment, decreases the duodenal pH to the acid side, reduces the mucosal blood flow because of smoking, and also inhibition of the prostaglandins. Prostaglandin inhibitors. Smoking is a powerful prostaglandin inhibitors, and prostaglandins are protective for gastric ulcers and gastric problems. So I told you that we are going to look at the stepwise approach. What is that stepwise approach? Okay, patient has come with dyspeptic symptoms. What are dyspeptic symptoms? Burning, bloating, belching, burping, mass, anemia, dysphagia, and the like. For how long? Not 1 day or 2 days, at least 4 weeks. The symptoms must continue to be present for 4 weeks. Then, immediately, my first step would be, does the patient, he or she, has alarm signs or no alarm signs? What are alarm signs? Mad blow. M is mass in the epigastrium, A unexplained anemia, and then D dysphagia, progressive dysphagia, BL blood in the upper or lower GI tract, and then LOW loss of weight of unexplained nature. If you find any one of these mad blows, immediately the patient should undergo upper GI endoscopy. No waiting, not after 6 weeks or 10 weeks. So whenever you have the alarm signs, immediate upper GI endoscopy is the order. Where from I am talking? I am talking from the international NIC guidelines, NICE guidelines. Suppose the patient does not have alarm symptoms. He is only having dyspeptic symptoms, no mass, no anemia, no dysphagia, no blood in the stool or in the vomit, and no loss of weight. And then what is the age of my patient? If he is more than 55, upper GI endoscopy immediately. Less than 55, you can treat as uninvestigated dyspepsia. Empirically, you can treat for 4 to 6 weeks. The symptoms resolve, fine. If they do not resolve, then do the endoscopy. You understand? So if a patient of dyspepsia comes to your chamber, first thing is, are there alarm signs? If yes, same day endoscopy. If there is bleed, immediate urgent endoscopy. No alarm signs. What is the age of my patient? More than 55. Again, same or next day endoscopy. No delay, because as age advances, malignancies do increase. And if it is less than age 55, then we have uninvestigated dyspepsia. We are justified in treating, giving empirical treatment. Okay. Okay. What is the second step? There are no alarm signs. So I did not go for endoscopy. Age is less than 55. Alarm signs absent. Age less than 55. This patient qualifies for uninvestigated dyspepsia empirical treatment. Or the option is, you can test for H. pylori and treat the patient. Treat and test is one option. Test and treat is another option. Both are good options only. So if you decide you don't want to test for H. pylori, you can as well treat the patient with empirical treatment as uninvestigated dyspepsia. The third step is alarm signs are present or the patient is having age of more than 55 years. That means the two qualifications for immediate endoscopy are met. One is the presence of alarm signs, mad blow, and age is more than 55. Any one of the two is there. Naturally, I will be ordering an upper GI endoscopy. Before that, suspend all NSAID medication. How about small dose of aspirin? He is taking 75 milligrams of aspirin or clopidogrel. You need not stop. 75 milligrams of aspirin at that dose is not going to cause bleeding. If there is bleeding, of course, you will stop. Other alarm signs like mass, loss of weight, dyspepsia, we are not going to stop the aspirin or clopidogrel. If the patient is having bleeding, of course, I will stop the antiplatelet agents. All NSAIDs must be temporarily suspended. Review all medications, whichever you think are culprit medications for dyspepsia, you stop them. And after the endoscopy, you classify the disease. What could be the classification? GERD, PUD, non-ulcer dyspepsia, functional dyspepsia, malignant. Okay, this is the classification. Upper GI endoscopy, at least 2 weeks you stop PPIs, routine endoscopy, I'm saying, not emergency endoscopy. You stop PPIs for 2 weeks or H2REs and then do the endoscopy, except in emergency and upper GI bleeding. NSAIDs and other ulcerogenic medications should be suspended for 2 weeks before doing the endoscopy. All patients treated as undiagnosed dyspepsia should be referred to upper GI endoscopy if there is no relief at the end of 4 to 6 weeks. What is the fourth step? Upper GI endoscopy is done. This fellow is not a candidate for immediate endoscopy. I treated him for 4 weeks or 6 weeks with standard treatment, empirical treatment, no relief. Then we did an upper GI endoscopy. Non-ulcer dyspepsia, chronic gastritis is one category. Ulcer dyspepsia, gastric ulcer, duodenal ulcer, together are called the peptic ulcer. That's the second category. Gastroesophageal reflux disease and gastric malignancy. The patient should be classified like this. If you see an endoscope report which does not classify this way, you must ask the endoscopist to say clearly whether it is NUD and CG or cancer or GERD or GU or DU ulcer. It is a diffuse erythema found, this found, that found, no description is important. The diagnosis should be NOD, chronic gastritis, GERD, PUD, gastric and duodenal ulcer, and then gastric cancer. If none are there, it means there is no lesion and could be functional dyspepsia. Treatment of uninvestigated dyspepsia, that means patient doesn't have alarm signs, less than 55 years. I have put him empirically on medication. Lifestyle measures must be followed. What are my lifestyle measures? Reduction of weight, smoking, food and bed should be at least 2 hours separate, and left lateral position, slanting position, sleeping. These are important lifestyle measures. Full dose PPI for 1 month, followed by PPI or H2RA, like ranitidine group of drugs are called the H2 receptor antagonists. Proton pump inhibitors are the omeprazole, esomeprazole, pantoprazole, lansoprazole, and things like that are called the PPIs. 1 more month you give and not relieved after 2 months, then you do endoscopy. Non-ulcer dyspepsia. Okay, you have done the endoscopy, you did not find any changes. Endoscopy is normal. Non-ulcer dyspepsia, medications are important. Lifestyle like previous way. What are the medications? Now I have to test and treat for H. pylori because dyspepsia without there being ulcer could be H. pylori. Then treat and test H. pylori and then low dose PPI or H2RA for 1 more month and no repeat endoscopy for NUD because there's nothing they're going to get any information. The persistent symptoms are there, low dose PPI and self-care PPI. That is PPI on demand, it is called. Now, what are the extra esophageal manifestations of GERD? It's an important short notes question. Extra esophageal manifestations of GERD. Somebody comes with persistent cough for 1 or 2 months. Consider dyspepsia. Treat the dyspepsia and GERD. Cough disappears. We have n number of cases whom we have treated like that. Posterior laryngitis, hoarseness of voice, laryngitis, hacking cough are to be considered when cause is dyspepsia. Laryngeal stenosis, aspiration, repeated asthmatic attacks, repeated sinusitis, you consider GERD. Complications of GERD, esophagitis, peptic stricture, Barrett's esophagus, esophageal ulceration, upper GI bleed, and of course, adenocarcinoma of the esophagus, which is on the rising trend. So this is what is called the Barrett's esophagus. If I see, you can see this is the gastroesophageal junction, and above the gastroesophageal junction, entire esophagus become red, and then the epithelium there should be normally columnar epithelium that is replaced by the squamous metaplasia, the squamous epithelium. This is a forerunner. Barrett's esophagus is a forerunner for the esophageal cancer. Columnar lined distal esophagus. Distal esophagus normally is lined by squamous, that is now replaced by the columnar epithelium due to metaplasia, that is called the Barrett's esophagus. How do I treat GERD? Lifestyle modifications and medications. Full dose PPI for 2 months now. GERD, longer treatment. Then double dose PPI for 1 more month, and then add a prokinetic like domperidone or any other prokinetic in addition to PPI. Then H2RES and prokinetics for 1 more month. Review the diagnosis if no response. And finally, low dose maintenance treatment. Return to self-care with antacids. This is the management of GERD. This is the only condition apart from hiatus hernia where you have got a chance to use the prokinetics. Left and right, don't write Pantop D, Nexpro D like that, because the domperidone or the prokinetic is not indicated unless there is GERD, unless there is gastric motility is decreased, unless you have evidence of hiatus hernia. How do I test for H. pylori? Urea breath test, fecal antigen test, fat test, and serology. Urea breath test is expensive, not available everywhere. Fecal antigen test can be done, or endoscopic material can also be tested for the H. pylori antigen by a card test, ELISA, or something. So urea breath test I am just skipping, but I will share the slides with you. The pathogenesis of ulcers, there are aggressive factors and there are defensive factors. Aggressive factors are acid, pepsin, bile salts, NSAIDs, H. pylori. Defense, mucus, bicarbonate, good blood flow, cell renewal, prostaglandins, phospholipids, free radical scavengers are all defensive factors. There is a tug of war between them. The defensive factors are good, no ulcer formation. If the defensive factors are weak and the aggressive factors take over, there will be ulcer formation. How do I treat peptic ulcer? Lifestyle modifications, H. pylori test, urea breath test, stool antigen or antibody, H. pylori, and eradicative treatment for H. pylori with 3 drugs. One of them is omeprazole or PPI. The second one is clarithromycin, 500 milligrams BID. Third one is amoxicillin, 2 grams BID. Amoxicillin, clarithromycin, and the PPI together have to be given for at least 2 weeks. Full dose PPI for 2 months plus 1 more month. Stop NSAIDs, decrease the dose. Selective NSAIDs like celecoxib you can use. Gastroprotection can be offered with misoprostol 200 micrograms. Misoprostol is used for medical termination of pregnancy. That comes very handy to give gastric protection. Now, repeat endoscopy after 8 weeks to see whether the ulcer has healed or not. If the ulcer is not healing with the above treatment, then there is something wrong which we have to think. Okay, NSAID is if used, 95% of duodenal ulcer 75% of the gastric ulcers have H. pylori. Stop NSAIDs, look for H. pylori. Repeat endoscopy after 8 weeks, retest for H. pylori. Consider low dose PPI. What is H. pylori? Helicobacter pylori is a gram-negative spiral-shaped flagellate bacillus which causes havoc in the upper GI tract. How do I treat? Combination therapy is the rule. You should not prescribe single drugs for fear of drug resistance. Eradication of H. pylori is essential for treating dyspepsia and for healing of the ulcer. Ulcers do not heal if H. pylori infection persists. Regimen consists of 3 drugs for 14 days, full dose PPI, BID, that is 40 milligrams of omeprazole BID or 20 milligrams of esomeprazole BID, clarithromycin 500 milligrams, amoxicillin 2 grams BID, not 1 gram. Today's recommendation is 2 grams BID, metronidazole 400 milligrams BID. Combination packs are available. Non-healing peptic ulcer. What are the causes of non-healing peptic ulcer disease? Non-compliance with medication, that means he's not taking the medicine or did not stop smoking. Ulcer turning to malignant, then also the ulcer won't heal, or H. pylori is resistant to the drugs you have used. False negative H. pylori, empirically treat for it. Inadvertent NSAIDs are ulcerogenic drugs. And rarely, Zollinger-Ellison syndrome, mucosa-associated lymphoid tumors, and Crohn's disease, multiple endocrinopathy 1, MEN 1. So what are the causes? This is a standard short notes question. What are the causes of non-healing peptic ulcer disease? 1. Non-compliance with medication, did not stop smoking. 2. Ulcer has turned malignant. 3. H. pylori is resistant to the drugs I used. 4. H. pylori test was initially negative, so I did not give. Now you empirically treat it as H. pylori. Number 5. Inadvertent NSAIDs or other ulcerogenic medications are being used. Rare causes are Zollinger-Ellison syndrome, mucosa-associated lymphoid tumors, Crohn's disease, and MEN1 are the cause of non-healing peptic ulcer disease. Then the other category that is left, we have treated uninvestigated dyspepsia, non-ulcer dyspepsia, GERD, and then peptic ulcer disease. The fifth category is the functional dyspepsia. Here, only symptoms are there. Endoscopically, everything is normal. Patient is not responding in spite of treatment. Reassurance. Lifestyle measures are essential. Behavioral treatment are important. Suppress the acid with prokinetics. Antidepressant medications have to be used. So, what medications are to be looked for? NSAIDs and of course not low-dose aspirin. Steroids, oral and not inhaled steroids. All theophylline are ulcerogenic. Your derifilin, ecybrofilin, all these are ulcerogenic. Bisphosphonates also used for osteoporosis. They can cause ulcers. And then dyspepsia. Calcium antagonists, anticholinergics. Immediately suspend the medicines or reduce to minimum required dose. Selective COX-2 inhibitors instead of non-selective NSAIDs. Use a selective COX-2 inhibitor like celecoxib. What are the future therapies? Potassium competitive acid blockers, cholecystokinin 2 receptor antagonists, anti-gastrin vaccine, new PPIs like elaprazole, estantaprazole. The advantage of estantaprazole, it can be given twice a week, elaprazole once a week. H2RAs are OTC medications, over-the-counter medications like antacids. Immediate release formulations are also approved. And then points to remember: alarm signs, age more than 55, uninvestigated empirical treatment, UGI for diagnosis after 8 weeks of treatment and no response, peptic ulcer disease, must treat H. pylori, test and treat, eradicative treatment with 3 drugs. GERD is a strong predisposition for esophageal cancer and other stricture and other things. So very strong treatment, prolonged treatment is important, and you have to have prokinetic, no long-term PPI in general. NSAIDs are important to be considered in every patient. They should be modified or stopped. Use celecoxib like selective NSAIDs. If not responding, review the diagnosis. Repeat the scopy for none other than PUD. Only peptic ulcer disease requires repeat endoscopy to know whether the ulcer has healed or not. Prokinetic medications are indicated only when gastric gastroparesis, diabetic gastropathy, and then GERD and hiatus hernia. Self-care should be advised PPI on demand. I'm summarizing in this slide and I'm going to close it another 1-2 minutes. Uninvestigated dyspepsia, full dose PPI 1 month, further treatment PPI or H2RA upper GI endoscopy after 8 weeks. NUD, we did an endoscopy, non-ulcer dyspepsia, H. pylori test and treat, low dose PPI, H2RA 1 month, no repeat endoscopy. GERD, full dose PPI for 2 months, plus additional 1 month of double dose PPI, plus prokinetic, and review the diet. PUD, H. pylori test and treat, full dose PPI for 2 months, plus 1 more month, stop NSAIDs. You may protect with misoprostol. Repeat endoscopy is essential after 8 weeks to see whether the ulcer has healed. Functional dyspepsia, antacids, H2RA antagonist for 1 month, antidepressants, and cognitive behavioral therapy has to be instituted. So from 1970s to 2025, no acid, no ulcer was the done. Now acid plus pepsin plus decreased defense. Hurry hypothesis is ruled out. Now obesity, lower esophageal sphincter pressure is reduced. Fats and smoking are incriminated as causative agents. Earlier, fractional test meal and barium series were done. Now esophageal manometry, pH meters, and urea breath test are used. Antacids were used left and right. There are no H2RAs and PPIs at that time. Today, PPI and H2RAs are available. Antacids have a limited role. H. pylori was not considered important. In 70s, H. pylori is the culprit, must be tested and treated. PUD and carcinoma of stomach are more in 1970s. Today, GERD, functional dyspepsia, carcinoma of the esophagus are more and not carcinoma of the stomach. NSAIDs are less important in those days. NSAIDs share a central role in the prevention and treatment of dyspepsia. A long way we came from antacids to antibiotics. Why do we miss carcinoma of the esophagus or stomach? I told you about 3% of patients have dyspepsia, have carcinoma of the upper GI tract, 25% have cancers without alarm signs, alarm symptoms, 68% have carcinoma. Endoscopy is not appropriately used. That means those who have alarm signs, those who are more than 55, endoscopy must be done on the same or the next day. Do not waste the time. H. pylori was not considered at all. That's why that has resulted in chronic peptic ulcer disease, which became malignant. We have not reviewed medications. NSAIDs particularly have to be considered. Self-ulcer medications are used until late stages without endoscopy. Alarm signs, no urgent endoscopy is done. And also, that is why I'm saying patients will ask, give me tablet and don't put pipe. Matrai kudunga, pipe vendam in Tamil means give me tablet and I don't want pipe. You have to change the behavior. Tell them they must undergo endoscopy, particularly if they're above 55 and they have sort of the alarm signs, or if the dyspepsia is not responding after 2 weeks, 4 weeks of intense treatment. This is the end of the show. So that's nice of you to attend.